guess I'm the only thing between you guys and the rest of Saturday afternoon, right?
Yes.
Oh. So we're going to have a short 2-hour session. No. I think we're starting early, so that technically means we should end early, right? Okay. All right, so as a neuro-ophthalmologist, of course, pupils are one of my most important things that we look at. And whoever's worked with me knows that I don't let my technicians ever dilate the pupils. I don't let my residents ever dilate the pupils because I need to see the pupils oftentimes to try to figure out what's going on with the patient. So this talk, I'm hoping, will be a bit about that, about why is it so important to look at the pupils and, in my opinion, from the technician standpoint, not to let the buck stop with you. If there's a question about the pupils, please get your doctor, and hopefully it'll become evident as we talk about some of these conditions why it's important to look at the pupils. And if you're not sure, don't just dilate the pupils. Ask the doctor to check and see if you're on the right track or not. So, I'll start just with this to get people thinking. And this is a young guy with blurry vision. I'm going to ask you which eye has the blurry vision in a minute. And we'll see sort of the basics of a pupil exam, looking at the direct and then swinging the light. And can people tell me which eye has the blurry vision? Right, very good. So this person has a moderate bright relative afferent-pupillary defect. Hopefully, and I think everyone pretty much, there was a nice response from the audience. In unison, it was the right, so I think everybody saw this. The problem, of course, is that it won't always be this obvious. And so later, a little bit later on, we'll show some other examples of APDs, or maybe not, and I'll ask you maybe some tougher ones to look, and we'll talk about what sort of things we really want to look at when we're looking for relative afferent-pupillary defects. So my objectives are that when we're done, you'll be able to identify not just a big relative afferent-pupillary defect, but a small relative afferent-pupillary defect. We'll talk about anisocoria. Of course, you'll be able to identify that and why that's important, and then list conditions your doctor may miss if you don't find them and then dilate the pupils. Because, of course, once you dilate them, relative afferent-pupillary defects and anisocoria can no longer be identified. And so I'm not going to talk a lot about anatomy. It's good news. But I think there is a little bit of anatomy you probably should know. And if you know just a little bit of anatomy, you can figure out most pupil problems. And you see the red arrows. So when light comes into your eye, it's the retina. It goes from the retina back along the optic nerve. There's a decussation in the optic chiasm, which is right here. And half the signal goes, about half, goes to each the left and the right side of the brain. There's another decussation in the back. Oops, I don't have it drawn too well, but back here, there's another decussation. So by the time the signal that you shine in, the light you shine in one eye, by the time that signal gets back to your eyes along the, and this is the afferent pathway, that's why we call it a relative afferent pupillary defect. Afferent means as stuff goes from the outside towards your brain. The efferent side is coming back from your brain, in this case, to your eyes. And so this is primarily the third nerve, the oculomotor nerve. And this is the parasympathetic fibers that go to the iris sphincter muscle. And so the point of these arrows is by the time that light signal gets in one eye, decussates, which means splits in half, once in the chiasm. Again, in the midbrain back here, I can get my pointer, everyone can see that back here. By the time that splits twice, both third nerves get the same signal. And so what happens? If you shine the light in one eye, both pupils constrict equally. And that's the anatomic basis. If you understand that little bit of anatomy, then you can understand most pupil problems. Certainly you can understand relative afferent pupillary defects. And that's not all the story behind the anatomy, one little bit. So that was the parasympathetic pathway, the pathway that ends up at the iris sphincter, but we also have in the iris dilator, and a separate set of nerves called the sympathetics. So the sympathetics follow a different pathway. They start in the brain in the hypothalamus, and then the blue arrows on the graph here, or on the schematic, come down the spinal cord. And I tell my patients, this is a wacky thing. Why do they do this? Instead of starting in your brain and going like this towards your eye, they go down your spinal cord, all the way to the top of your lung. They come out around that point, over the top of the lung, back up the internal carotid artery to several places, one of which being the dilator muscle, and another being a muscle in the upper lid called Mueller's muscle, which keeps the eyelid open normally. And we'll talk about what happens when there's an abnormality of the sympathetics. But this has got nothing to do with relative afferent pupillary defects, which is one of the main things you're looking for, and one of the main points of the talk is to be able to identify RAPDs. But there are other problems that some of you may know, some of you may not, that can happen if there's a problem with the sympathetics. And we'll talk about that after we talk about relative afferent pupillary defects. So the consensual light response, we just talked about why we have a consensual light response. The consensual light response simply is that when you shine light in one eye, like this, you have to use this pointer since we've got 3 screens, but when you shine the light in one eye, both pupils constrict equally. You shine the light in the other eye, both pupils constrict equally. Here is a video demonstration of that. So watch the pupil that doesn't have the light, and you'll see the consensual light response. And so if you know the anatomic basis, why does this happen? 2 words. Why do you have a consensual light response? 2 words. 2 words are double decussation. There's that first decussation in the chiasm, second decussation in the midbrain, and that's the 2 words for why you have a consensual light response. Does that make sense? Everybody, yes? No? Yes? Okay, too basic, maybe? Okay. Just to make sure we're all on the same page. Double decussation, both third nerves, same signal, both pupils, same signal, same constriction of both pupils. Okay. So when we talk about the pupil exam, of course we're going to look at reactivity. That's sort of what we were talking about. We want to note the shape. Now, most pupils are round, and I don't write round if they're round. But if they're not round, I'm going to write or probably draw a picture with electronic medical records. You probably have to describe it unless you can draw it in your electronic medical record. But you want to note if it's not round. If I don't see any comment on shape, then I'm assuming they're round. They can be round and not in the center of your eye, or in the center of the iris too. So here's a pupil way over here in the congenital condition. That's pretty unusual, but sometimes after eye surgery or eye injury, the pupil may still be round, but it may not be centered. I would expect a note about that too if the pupil's not centered. The size is important, but that doesn't mean I whip out that near card with a little pupil gauge, 3 millimeters, 4 millimeters. If you say they're 3 millimeters and I say they're 4 millimeters, I don't care. If you say they're 2 and I say 8, no, that's a problem. But as long as you're close. But that only goes for the size of the sort of the absolute size of the pupils. If you say they're both 3, and I say one's 3 and one's 3.5, that's a problem. Because if there's a difference in size of the pupils, anisocoria, that could be the underlying sign of some potentially bad stuff. And we'll talk about those things when we talk about anisocoria. So I don't care if you say they're 3 and I say they're 5, even that. But I do care if you say they're 3 and I say 3 and 3.5, because a little bit of anisocoria may be important. And I'll try to demonstrate that when we get there. The reactivity, there are different schemes. I don't really care what scheme you use. I think the important thing is if you say they're mildly reactive or moderately reactive, you know what that means to you. So if you see the patient down the road and you said, yeah, I said that they were mildly reactive. Today they're sluggishly reactive. That's a change. So I think the most important is that you have some sort of a scale in your mind as to what your mild, moderate risk is. And if you see a patient again and they don't fit that, you can then say, ooh, a change. And that's what I would say about reactivity. And then fellow travelers. So what are the fellow travelers? Well, we talked a little bit about the anatomy, third nerve and sympathetics. And you guys know that the third nerve goes to more than just the pupillary sphincter, right? Where else does the third nerve go? Third nerve. Eyelid, so it goes to the levator muscle. So if I cut your third nerve, your lid shuts, right? So one of the fellow travelers is eyelids. If you see a pupil issue, you want to look really closely at the eyelids. What else? What's that? I heard someone say, yeah, the eye movements, right? Because if someone has a third nerve palsy, like this person in our screen on the bottom here, she's being asked to look to the left. You can also see the finger sign holding the lid open. So this is the same person that's up there with the ptosis. This eye's not moving. This person has a third nerve palsy. Now this is really obvious. They're not always going to be that obvious. But if you see a pupil problem, in particular, oh, there's a little difference in size of the pupils. Your next thought should be, what about the lids? And this person, what do you think about this person's eyelids? So this will be the left eye. So there's ptosis here. It's not obvious. It's not obvious because if you look at the top of the pupil, there's about the same distance from here to here as there is from here to here, but look at how small this pupil is. So this person has a small pupil and they have ptosis, relative ptosis on that side. How would you count? You could just take out the near card with a ruler, hold it up, measure the interpalpebral fissure, which would be just right where the eyelashes come out here, right in the center of the lid versus here. Oh, that's 10 millimeters. Over here, oh, that's 9 millimeters. Is that important? Maybe. This is a problem we'll talk about that can kill you. So it might be important to the patient. So you got to look closely. Sometimes it's very obvious, like in the upper frame, the upper picture, obvious ptosis. You're not going to miss that. But what about in the middle one? Are you going to note ptosis? And remember, when you put drops in the eyes and you affect the size of the pupils, you also are going to affect the height of the eyelids. When you put dilating drops in this person in the middle with her problem, which we'll talk about, there will be no ptosis in 20 minutes because the drops that you put in to dilate will make that lid go up. And so now you've lost both of the findings. So it can be subtle. You want to look closely for the fellow travelers. Lids and eye movements. And questions about any of that stuff, because that's sort of the anatomy stuff that I wanted to get through. Any questions? Clear? All review? You knew all that already? Okay. All right, so we already showed you one video. I'm going to show it again in a moment. Probably, maybe one of the two most important pupil things is this relative afferent pupillary defect. And you guys who work here, how many people work here? How many people don't work here? I should ask that. Okay, so some of you don't. Okay. You guys know if your doctor says, oh, this patient needs to see Dr. Golnik, and you call me and they say, yeah, the patient's dilated, I say, not today. I'll see him tomorrow or the next day, but not today because you've taken away that pupil. And sometimes I can tell you what the doctor says when I say, well, is there a relative afferent pupillary defect? Well, the technician said no. Okay. But, and then they say, but that doesn't mean there might not be a small relative afferent pupillary defect. So I need to see the pupils. And it's nothing against technicians. I feel the same way about your doctors. Because sometimes the technicians are better than the doctors because you look. So this is the basis of a relative afferent pupillary defect. Here we have another schematic. I'm going to show you a video. But you can see here's the light being introduced. You'll notice that both pupils constrict. Consensual light response, right? Double decussation. The light is swung over to the side. Now if you ignore the panel, the second panel down for a second, and you just look at the third panel compared to the top, you'll say, oh, both pupils are smaller, right? So they are smaller than the resting state. But when you swing the light back, they get even smaller. So you go from the second panel, and the pupils get a little bigger, and then you go down to the bottom panel. When you swing the light back to the right eye, and the pupils get a little smaller. So what's that telling us? Simply that there's more light getting to the patient's brain along the right optic nerve than along the left optic nerve. And the patients, and I'll say, oh, it's left, right, or yeah, wow, you are a good doctor. How did you know that? Because the pupils, there's a relative afferent pupillary defect. So the more fibers that don't work, the less light the patient senses and the dimmer things are. And so sometimes, you're not sure, this changes the relative afferent pupillary defect from a totally objective finding to subjective. I'll say, well, is it about the same brightness? Yeah, it's about the same. No, it's way brighter in one eye than the other. And the problem with that, and think Dr. Saltarelli sort of alluded to this somewhat in his talk, is that patients will say the darndest things, and sometimes if they think there should be a problem with the eye, they say, yeah, it's brighter in that eye, even though there's a big APD. So you got to be real careful making it into a subjective test. Try to keep it objective, meaning you're observing it. The patient doesn't have to tell you one thing for you to see this finding. And so if there's a relative afferent pupillary defect, usually, we'll talk about some exceptions, there's a problem with the optic nerve, which is why neuro-ophthalmologists own relative afferent pupillary defects. There's some sort of problem with the optic nerve, with the afferent system, right? The afferent. That's why it's called relative afferent pupillary defect. And here's our guy that everybody correctly identified. Should be hopefully really easy. To give you an example of how doctors sometimes don't look at pupils very well, we had a patient some years ago in the intensive care unit, and in the chart, the neurosurgeon wrote, perla. Pupils are equal reactive light and accommodation, and the person had a prosthesis on one side. So this person has an obvious relative afferent pupillary defect. This is a young guy, pain around the eye. He had optic neuritis and multiple sclerosis. So for instance, here's a finding. This might be the only finding you see in optic neuritis, other than the vision is blurry to some extent. The optic nerve may look completely normal in the back of the eye. So when you dilate that patient and the doctor looks in, they'll say, oh, everything's normal. Was there a relative oh, I didn't think there was a relative afferent. I'm not sure. Well, either be sure or get your doctor to look at the patient's pupils, because there's this old saying about retrobulbar optic neuritis, where there's no swelling of the nerve. The patient sees nothing, the doctor sees nothing, except for the relative afferent pupillary defect, unless the patient's pupils are dilated. So, of course, the pupil exam, you have to swing the light. If you just shine the light in each eye, you're not done. You have to swing the light from side to side. Sometimes people say, well, how many times can you swing the light? And you can affect the system. I mean, if you keep swinging the light and you put more light in one eye, maybe there's a left relative afferent pupillary defect, and you swing the light, and you go like this, and you look, and you go like this, you can actually create a small APD in the eye you're shining the light in more. Because it can bleach out the retina, and that can actually cause a little APD. So you can affect the system. And the real pupil gurus say, if you have to swing the light more than 4 times, put the light away, go on with some other part of your exam, and 5 or 10 minutes later come back and check again. Because you can affect the system with your bright light. All right, so let's look at a few patients here, and no one shout anything out, just sort of think to yourselves. And my question is there a relative afferent pupillary defect? And this video is just looping, so. Okay. We've seen the swinging flashlight test. So how many people think there is no relative afferent pupillary defect? So a few people. How many people think there's a right relative afferent pupillary defect? How many people think there's a left relative afferent pupillary defect? Okay, so I have some hands, not everybody raised their hand, that's okay. So the thing you want to look for when you're swinging the light is the initial reaction of the pupil. And when we swing the light, this pupil always comes down a little bit. And this pupil stays the same or gets a little bit bigger. And it stays the same, smaller. So this is a really subtle right relative afferent pupillary. Subtle right relative afferent. But you want to look and compare just the initial movement when you swing the light. And you want to swing it quickly like this. And if one pupil comes down every time you swing the light, the other one does nothing, I'm going to say I think there's probably a little APD. If this one does nothing, and this one comes down every time, it's an asymmetric. If they both come down a little, no. If they both do nothing, no. So I'm looking for asymmetry when you swing the light. This one's probably, I think this is the toughest one I got. And I'll write sometimes. Question, trace, right, relative afferent pupillary defect, or think it. Question, trace, and then what do? Well, I look at their acuity, I look at their visual fields, I look at their color vision, I look at their nerves. And sometimes I'll say, nah, it's all normal, I guess not. But if I find anything that's asymmetric with the vision, the color vision, the fields, the nerve, I'm going to say, aha, I think I'm right. But I'll write question, trace, APD sometimes. Okay, here's another one. Think about it. Don't yell out your answers. So this one's a tough one, I think, too, because when I look at it, initially, I have an impression, and the more times I swing the light, the less certain I am. So how many people think there's no relative afferent pupillary defect? Okay, how many people think there's a right relative afferent pupillary defect? Left relative afferent. Okay, so I would agree with you. Now, but as we watch the video, initially I'm thinking, oh, that pupil doesn't do anything and comes up a little bit, but then as you swing it and keep swinging it, it looks to me like that left pupil reacts a little bit better. There's a little downward, and that's what I'm saying about that light. So I'm going to swing it a few times, have an impression. I'm going to go on, I don't know, look at the slit lamp or whatever else I'm doing, and then I'm going to look again in 5 minutes to see if I think the same thing. All right, let's look at another one. Okay, so this one, APD, what do you think? Left. Okay, so this is a, I don't know, mild to moderate left relative afferent. Clearly an asymmetry when you swing that light from side to side. Yes? Okay. And I got one more. What do you think? Right? You're a right? So this person has a small right relative afferent. Watch the initial movement when you swing the light. Up a little, down a little. Up a little, down a little. Yes? So it's small. But that's what you're looking for. You're looking for an asymmetry. And if it's small like this, and you're not sure, ask your doctor to look. I know everybody's busy. Everyone wants their patients dilated. Why it's taking you so long? Yes? Yeah. Yeah, so I don't, you know, it doesn't, I don't care. I feel the same way about that as I feel about how you grade reactivity. Whether it's 1 plus 2 plus, I don't care. Whether it's mild, moderate, I don't really even care if you grade it. Why not? You take an old person, pupils barely react. You swing the light, I think there might be a little APD. Take a young person, pupils briskly reactive. Big difference, big asymmetry. That old person with those small pupils, it may look small, but it may be a bad APD. When I was a fellow, my first day of fellowship, there is a way you can grade these with camera filters. You can actually put filters up that screen out light. And you can put filters up until you equalize the pupils and say, oh, this is a whatever grade pupil, afferent pupil. First day of my fellowship, my preceptor, as I was presenting the patient, I said, well, I think there's a 2 plus. And he said, either they have one or they don't. Who cares if it's 1 plus, 2 plus? The whole point, especially from a technician standpoint, the whole point is there one there or not? Because whether it's mild or bad, that tumor could be doing, if you got it early, you got it late. Or multiple sclerosis or whatever it is, whether it's mild or severe makes no difference. Especially from a technician standpoint, it's up to your doctor to figure out why they've got it. The question is, do they have it or do they not? And I see people all the time who misgrade them. I don't care whether you can detect one or not. And so I said earlier, most relative afferent pupillary defects, at least, I think in general, if you work for a retina specialist, that's an exception, are due to optic nerve problems. Retinal damage can do it. And if you have a retinal detachment and the other eye's fine, if you have a central retinal artery occlusion, you're going to have a relative afferent pupillary. So certainly a bad retinal problem can cause a relative afferent pupillary defect. But things like cataracts don't. Refractive error, no. Right? So all the other things that might affect your vision shouldn't cause relative afferent pupillary defects. You can see a little APD in someone with amblyopia. You can see somebody, this is what I mentioned, if I shine a really bright light in your eye for a minute and then swing it, you'll have a little tiny APD on that side. Similar, and it'll go away fast. As soon as you let your eyes get back to normal. Similarly, if the patient's wearing a patch. So a lot of times I'll see people with double vision. How do they treat it? Patch. What happens? My resident or my technician, usually my resident, comes into the room. Please take your patch off. Let's look at, oh, Dr. Golnik missed a small APD on the good eye. And they'll come out, well, it seems like you missed an APD on the good eye. And of course, by then we go back in the room to check. It's been 10 minutes. They're now light adapted, and there's no APD. You idiot! There's no APD. So monocular occlusion can do it for a short time until you're just like the bright light can do it. And then blood in the eye can cause an APD, but it's got to be really bad. 8-ball hyphema, so the whole front of the eye filled with blood. Dense vitreal hemorrhage that can do it. You guys probably don't have to worry about that too much. The point is, it's going to be very mild. So if someone has an injury to their eye and they've got a hyphema and a big APD, it's not going to be due to the blood. It's due to the injury, probably affecting their retina or their nerve. Those are fine points, but mostly it's going to be nerve, possibly retina. Sometimes people say, well, can you tell if there's a relative afferent pupillary defect if one pupil is dilated? And the answer is yes, but it's harder, and it's harder to be sure. So I'm going to show you the schematic, and I'm going to show you a video. So here's a patient that you quickly discover there is no consensual and there is no direct light response. So the arrow, here's the light being shown in the right eye, light in the left eye, light in the right. There is no consensual or direct response. This pupil does not work. This pupil is not going to tell you anything more. So you do not look at this pupil anymore. But you still swing the light. And what happens? When you swing the light here, this pupil gets bigger. When you swing the light here, it gets small. So that means that there is not as much light getting back that left side. Does that make sense? So sometimes you'll hear the term reverse. I hate that term because it's confusing. I'm just going to say the left pupil doesn't react, and there's a left relative afferent pupillary defect because I'm watching, as soon as I determine this pupil doesn't work, I'm watching the other pupil. So that's a fine point. I don't know, you probably won't run into that much. Let's look at a video. Here's a patient who has a third nerve palsy too. That's why the pupil doesn't work on the left. You can see she's exotropic and you've got the finger sign. Well, watch the pupil. And it's hard to see this one, but watch whenever we swing it back, that pupil comes right down. Which means when we swing it over here, the pupil comes up. So now it comes down. So not only does this person have a third nerve palsy, they have a second nerve palsy, right? An optic neuropathy. They have a relative afferent pupillary defect on the left. Make sense? Yeah, maybe. Okay. Questions about that? Probably won't run into that much. But the point is, if one pupil is pharmacologically dilated, you can still look for a relative afferent pupillary defect. And then the last sort of thing to say, I think, about relative afferent pupillary defects is that the R is for relative, right? So if I damage both your optic nerves 50%, there will be no relative afferent pupillary defect. Sometimes I'll have a patient, they have MS, or they might have MS, they had optic neuritis, it improved a lot, there was still a chronic small relative afferent pupillary defect. They come back for a follow-up visit, my resident sees them and says, oh, good news, they don't have the relative afferent pupillary defect anymore, but their vision's blurry in their other eye. Well, they canceled it, right? They had a relative afferent pupillary defect here, and now they don't because now they have optic neuritis in the other eye. So if you have symmetric damage, there will be no relative afferent pupillary defect. This is an MRI with a large tumor. Here you can see both optic nerves heading into that tumor. This is a retired DuPont executive who came in. He had surgery in a big East Coast city, cataract surgery on one eye, and his vision really didn't get any better. And he then retired and moved and came to where I was practicing at the time, and he sent him to one of his friends there, cataract surgeon, and the cataract surgeon said, gee, I don't know, that didn't help your first eye. Maybe it won't help this eye. Why don't you go see Dr. Goldman? So I saw no relative afferent pupillary defect. 2200 OU, no APD, and he's kind of like, I don't know, I don't really care. He didn't really care about it. This is like this high-powered executive. His wife's like, you know, he retired too young. He's like 59. he kicks around the house, he's kind of depressed. And I said, well, I don't know, I can't really find it. The nerves looked okay, no APD. And I said, yeah, we should image him. And she said, no, you don't think he has a tumor, do you? And I said, nah, but he did. And he did very well when the tumor was removed. It was benign, and his vision recovered in 2025, OU, and then he needed the cataract surgery in the other eye. So that's the nuance for the R's for relatives. So just because someone has no AP doesn't mean they're great. Okay, I'm going to switch from APDs to anti-sequoia. Any questions about APDs? Yes?
This might be a silly question, but if they have a prosthesis in one eye,
Right.
possibly an AP in the eye that they have.
So the question is if they have a prosthesis in one eye, then you can't tell if there's there's going to be a prosthetic, whichever eye is prosthetics that have by definition an APD. And that does get to one other good point, and that is, what if this person has a long history of left optic neuropathy in their hand motion, and then they come in the other eye, so they got a big APD. And they come in with blurry vision in the other eye, and they still have a big APD. Well, if it's 90% here, and it's 50% here, they still have an APD here, right? So that's a tough situation, at least if the pupils don't help you very much. Because unless that is symmetric, there's going to be that APD in that eye that has that historically bad optic nerve problem. Are there any other questions about APDs? Yes? No? Okay. All right, so let's talk a little bit about So hopefully you'll all be able to identify APDs, and if you're not sure, hassle your doctor. Don't let the buck stop with you. That's not your job. So, anisocoria. So there's a bunch of causes of anisocoria. By far the most common you're going to see is physiologic anisocoria, normal anisocoria. And depending on how you define it, in this study, defined it as 0.3 millimeters, which they said is the degree that you might see with the naked eye without taking pictures and measuring them on a computer or something. So 11% of people, 1 in 9 of you, should have physiologic anisocoria. So every 9 patients you see, 1 should have physiologic anisocoria. I bet you don't record it that often. A couple of the characters about physiologic is both people should react just fine, right? So both people are going to react just fine to light. This is normal. There should be about the same degree of anisocoria in the light and the dark. So one of the first things you should do when you see anisocoria is, of course, how do the pupils react? Normal. Turn the lights off. Turn the lights on. Is there about the same amount of anisocoria? And if there is, it's probably physiologic and it's no big deal. And you can do what's called the FAT scan, family album tomography. Look at old photographs, right? Sometimes they'll say, I don't have an old photograph. How about your driver's license? Oh, the picture's bad. Pull out your 20 diopter lens, muscle light, magnify it up, and you might be able to detect it. And so the problem is that this condition, Horner syndrome, can look like physiologic anisocoria. So Horner syndrome is a problem with that sympathetic chain that we talked about, where I tell the patients, yeah, this nerve has a funny course. Starts in your brain and goes down your spinal cord, over your lung, back up your internal carotid artery, to ultimately to a couple of places, a small muscle in your lid. Not like the levator, not like a third nerve palsy, where if I cut your third nerve, your lid shuts. You're only going to see 1 to 3 millimeters of ptosis if there's a problem with the sympathetics. And you're going to see a smaller pupil because the fibers go to the iris dilator. The iris dilator is not working, so the sphincter is working unopposed, and so you'll see a relatively smaller pupil. So you're looking for miosis and ptosis primarily. Anhidrosis means sometimes there's poor sweating. And sometimes people will know that, young people who exercise, yeah, it's funny, my headband gets all sweaty on one side, it doesn't get, but most people don't really know about the sweatiness. And the key thing is, and one of the key differentiators from physiologic anisocoria is that when you turn the lights off, there's going to be more anisocoria. Why? Because the dilator's not working. And in the other pupil, it is. So you turn the lights off, the dilator muscle in the normal eye does what it's supposed to do, makes the pupil bigger, but dilator muscle in the abnormal eye not working well doesn't make the pupil bigger, or makes it a little bigger, but not as much as the other side. So there's more anisocoria in the dark than in the light, unlike physiologic. So here's photographs of that. So here's the anisocoria in the light. Notice a little bit of ptosis, somewhat smaller pupil in the dark, a little blurry photo. This pupil really didn't get much bigger, and the normal pupil did. So this was that quick. Lights on, lights off. Oh, there's more in the dark. Maybe this is a Werner syndrome. And it can be subtle. It can be subtle. So here's the eyes I showed you. This is a cover of a magazine. Being a good neuro-ophthalmologist, I immediately noted the anisocoria. And the ptosis, which is not very obvious. Not very obvious at all. And that's why when I see anisocoria, I'll look for ptosis, but I'll just whip out my near card. Oh yeah, there's a millimeter difference. That's interesting. And here's that same person. And there's something else that we look for, you guys can look for, that if you find it, it means there's a Werner syndrome. And it's called dilation lag. And I'm going to show you a video. So this video will start right when the lights are switched off. Look at this nice red reflex here. No red reflex here, right? Real time, watch what happens. He's developing a red reflex. Why? The pupil's getting bigger. It's getting big enough to have a red reflex. So watch when the lights go on, and look how subtle this is. Pretty subtle. Lights go off. Let me show that again. Lights are off. Right pupil, normal pupil, immediately gets bigger. Left pupil slowly gets bigger. So there's more anisocoria at the beginning and less anisocoria after 15, 20 seconds. And when the lights go on, look at how much ptosis and look how much anisocoria there is. And yet, you could have something that will kill him. So when you think about that, when you think about your pupil exams, so the question is, what are the complaints with Werner syndrome? Oftentimes, none. So they may have absolutely no complaints. The most common complaint related to the Werner syndrome is my lid's droopy, not my pupils are different in size. And so oculoplastics sends me bunches of people with this. Oh, they were sent to me for ptosis. Oh, they have a little difference. Is it a Werner syndrome? And so oculoplastics sends me a bunch of people, but other ophthalmologists and optometrists who find anisocoria will send the neurologists, will send me patients. The patients are most often asymptomatic, other than maybe the ptosis. And so here's one of the reasons that we worry about Werner syndrome. As I said, that sympathetic chain travels in the wall of the internal carotid artery. So that's that big blood vessel that brings blood to your brain. It travels in the wall. It's something that can happen after fairly minor neck trauma, a mild motor vehicle accident, a little whiplash. I saw a high school coach who was coughing a lot. A university professor was cleaning his bookshelf for an hour, and he had to do this to try to move all the books. And they all ended up with Werner syndromes. And the reason they had them was that there was something called a carotid artery dissection. A carotid artery dissection means that a little hole gets formed in the inner wall of the carotid artery. And when that little hole is formed, you imagine this blood rushing up, and it can get in that hole and dissect between the two layers of the artery, of the wall. And you can imagine that if it does that, here's this big fat internal carotid artery that the pulse you feel in your neck. Well, if this blood rushes upward and causes a big blood clot here, well, look at how narrow that blood vessel gets. And if that blood vessel gets narrow and the blood flow gets stagnant, you can form blood clots. And what happens then to your brain? You could be paralyzed forever. You could die from a stroke from this condition. And so when I see somebody with a carotid artery with sudden onset ptosis, often but not always neck pain, they go immediately to the emergency room for vascular imaging and, if they have a dissection, anticoagulation. But this can kill them. This is an MRI. This is over here. There's a little round black circle. I can't see very well. That's one carotid. This is the other carotid artery. This is the inside of the artery. This is the blood in the wall. In a carotid artery dissection. So Werner syndrome can be deadly. The other thing that causes Horner syndrome that all the medical students always learn about in school is if you have lung cancer in the top of your lung, it can present with the Horner syndrome. Because that lung cancer catches those fibers as they traverse the top of the lung. So it could be cancer. So when patients say, oh, my lid's a little droopy, I really need a scan. How bad could it be? Lung cancer, blood vessel problem, it'll kill you. Oh, okay. They usually get the scan. So Horner syndrome can be subtle. Yes?
I was with Dr. Hansen recently, and she tested somebody for Horner's. What is the difference between using regular eyelid drops and using eyelid drops?
So the question is, you can, and I wasn't going to get into that, but I'm happy to answer the question. You can check to prove someone has a Horner. So all the things I showed you are very suggestive. If there's more anisochlorine in the dark, if there's ptosis, if there's dilation lag, but to really prove it, the gold standard is cocaine drops. Yes. And I used to not tell my patients I'm putting cocaine drops in, and then about 10 years ago, a young guy called me 3 days later and he said, I had a random drug screen at work. It came back positive for cocaine. What did you put in my eyes? Cocaine. He said, I need a note. So now I tell everybody, after I put the drops in, I put cocaine in your eyes. The way it works, the reason it's different, is that what cocaine does, the other dilating drops directly affect the muscle, the iris sphincter muscle, by paralyzing it, and the iris dilator muscle by stimulating it. What the cocaine does, it causes the release of the stored neurotransmitter, the norepinephrine. And so in a normal pupil, if you put cocaine in, there's always some stored norepinephrine in the nerve. You put the cocaine in, it causes release of the norepinephrine, and the pupil gets bigger. But if you've got a Horner syndrome, and there's a problem with the nerve, there is no stored norepinephrine. And so when you put the cocaine drops in, nothing happens, because all it does is cause release, and there is nothing to release. So, modern medicine. Actually, not even that modern. So Horner syndrome, keep that in the back of your minds. And then third nerve palsy. So this is the other side, the parasympathetics and the iris sphincter. So you can see anisocoria from third nerve palsies. I won't reiterate all this. We already talked about it. All these muscles are innervated by that 1/3 nerve. So you're going to get a pupil that's big, doesn't react well, ptosis and ophthalmoplegia. And this is an example of someone with a severe third nerve palsy. There's no adduction, elevation, or depression. Sorry, it's just my laser pointer, but you can see that the left eye is moving normally. So this is complete. If someone walks in their office and their eyelid's shut and their pupil's big, you're going to say, oh, I know, this is obvious. But let's look at something that's not so obvious, because not all the patients read the textbooks. So here's another guy with double vision and a pupil problem, which I'll try to show you. And when he looks down, that left eye does not move all the way down. It does not move all the way in. Look at how well the right eye adducts compared to the left eye. And it does not move all the way up. Does it look like the last patient? No, because this third nerve is working 75% or 85% of normal. Is the underlying problem, does this have to say anything about what the severity of the underlying problem is? Absolutely not. In fact, I'd much rather see someone who walks in and says, yesterday my eyelid shut and they have a complete third nerve palsy, because that's usually diabetic, it's going to get better. Where someone like this, who happened to have nasopharyngeal cancer that killed him, has a mild third nerve, because the tumor or the aneurysm is just starting to push on that third nerve. It's not all of a sudden. She not worked, I guess. She lived on a farm, and I had seen her about 3 days after her pupils got different size. And she had already had an MRI, an MRA, a bunch of blood tests because of this. And they thought she had maybe this is an early third nerve palsy. But she had no ophthalmoplegia, no ptosis, no pain, just this big pupil that didn't work. And so I saw her about 3 days later, and I said, what does it look like? Anybody? Yeah, it looks like she's pharmacologically dilated. She's got a big pupil on one side. If you put drops in an eye there, it's going to look like this. There's no ophthalmoplegia. There's no fellow travelers we talked about. And I said, it looks like something got in your eye. And she said, I said, well, you live on a farm. You know, there's stuff out there, plants and things that can get in your eye. If you rub the plant, rub your eye, it can dilate your pupils. Well, it's a horse farm. So, all right. And you don't work out in the garden? No. And nothing in your eye? No. Okay, well, I got a drop. We're going to put it in. I didn't tell her, called pilocarpine, and it will tell me whether it's pharmacologic. And so this is her after the pilocarpine. What happened to the left pupil? Small and unreactive. That's what pilocarpine does, unless there's a pharmacologic blockade, unless something is getting in her eye. And so I went in 30 minutes later, and I said, ma'am, you know, it's clear that something got in your eye. I don't really know what it is, but it'll wear off. She said, well, but it's been 3 days. And I said, well, there are some things, there's some things out there that can dilate your pupils for a long time. She reached in her pocket, pulled out a wad of tissues, and in the middle of the wad of tissues, a tube of atropine ointment. And she said, well, could this do it? And I said, yes, but it's been 3 days. That'll last for a week. She said, I said, where'd you get that? And she said, well, my horse's eye had an infection or a problem, and they prescribed it for my horse, and then my eye started feeling funny, so I used the horse's medicine in my eye. And I said, why didn't you tell anybody before they spent $20,000 on your evaluation? And she said, I was embarrassed. Okay. So lack of history shouldn't dissuade you. If it looks pharmacologic, put the pilocarpine in and prove it, yes or no. And if you see the results we see, something got in the eye. I don't really care what, something did, and it will go away. And there are, as I mentioned, Jimson weed is something that exists. I was weed whacking not long moving after Ohio, wearing glasses, but got something in my eye, and my pupil got painted badly. So in summary, with pupils, you want to note the shape, the size, the reactivity. You got to swing the light to look for a relative afropupillary defect, and when you swing it, you want to look at the initial constriction, or the initial movement, I should say, of each pupil. Is it symmetric? If it's symmetric, no relative afropupillary defect. If it's asymmetric, probably relative afropupillary defect. And when you're looking at pupils, whether there's a 0.5 millimeter of anisocoria or 3 millimeters of anisocoria, the underlying problem could be the same. And so although it's true, most people with normal physiologic anisocoria are probably going to have less than 1 millimeter of anisocoria. So can't the aneurysm when it's starting to push on your nerve, or the Horner syndrome, and so on. So think about it before you dilate the patient's pupils. And if you're not sure, don't let the buck stop with you. Ask your doctor if you're not sure. I'd be happy to answer any questions about any of that. Yes?
With the surgery in process, correct?
So the question is, could surgery cause ptosis? Sure. I mean, if you have, if you're mucking around with the eyelid or you're stretching it or something, you might have a little ptosis after surgery, eye surgery or orbital surgery. Well, I think again, the surgery might cause a little ptosis, but hopefully, probably not the anisocoria. Okay. So you're looking for the fellow traveler. So when I see lids, I see ptosis. I look for the fellow travelers of ptosis, pupils and motility. Other questions or comments? Well, have a good Saturday.